Good morning, everyone, and welcome to today's Regional Geriatric Rounds webinar. My name is Heather McLeod. I'm the clinical team leader for the Geriatric Assessment Outreach teams here in Ottawa. Today, Dr. Sophie Hogeveen and Dr. George Heckman will be presenting on the Specialized Geriatric Services Decision-Making Tool. Dr. Sophie Hogeveen is a CIHR Health System Impact Fellow at Women's College Hospital and McMaster University. She completed her PhD in the School of Public Health and Health Systems at the University of Waterloo. Her research focuses broadly on health services delivery through the investigation of decision support systems and innovative care processes that make use of health system resources in a sustainable and equitable manner. Dr. Hogeveen's doctoral work investigated patterns of community-based specialized geriatric services used by community-dwelling older home care clients using secondary health assessment administrative data. Dr. George Heckman is the Schlegel Research Chair in Geriatric Medicine and Associate Professor in the Department of Health Studies and Gerontology at the University of Waterloo and an Assistant Clinical Professor of Medicine at McMaster University. Dr. Heckman's primary research interests include management of heart failure in long-term care and other frail seniors, primary care management of dementia, home care safety, and vascular aging. He is also the lead geriatrician for the Waterloo Wellington LHIN, and his work with the LHIN involves collecting an inventory of services and identifying barriers to seniors' care. He is an acknowledged expert in the field of frailty assessment and the inter-RI. Welcome, Dr. Hogeveen and Dr. Heckman.
Thank you very much.
Thanks, Heather. So thanks again to Heather for the introduction, and thank you everyone for being here. And I'll start off the presentation, and George will jump in. So what we'll do today is take a quick look at the state of care for older adults in Ontario, pre-pandemic, and as well as with the impact of the pandemic. We'll look at historical determinants of contact with geriatricians and consider a way forward to support and target appropriate referrals for the most vulnerable in the community. So to start off, we're going to rewind to 2018, pre-pandemic, pre-OHTs, pre-separation of the Ministry of Health and the Ministry of Long-Term Care. Feels like a long time ago, but it was in fact only 3 short years. So at that time, the Ministry of Health and Long-Term Care, as it was, tasked the Provincial Geriatrics Leadership Office with conducting an asset mapping project as a first step in capacity planning to understand the supply and use of health services for older people. And I know you heard a bit about this last month from Kelly Kay, for those of you who are in attendance. From the first phase of this project, several reports were produced with important insights. And this is not a very summarized version and not at all inclusive, but some of the findings included that there were many specialized geriatric services or SGS programs that exist, but due to their nature and the nature of the reporting systems in place, it's difficult to get a complete picture of the services available in our province. We know from the wait times and the wait lists, and anecdotally as well, we know that there is a high demand and need for these services. We also know that there are current and projected deficits of geriatricians across the province, with some regions being more affected than others. And the estimate deficit for 2025 was projected to be 157.4 full-time equivalent geriatricians, a deficit of that many. And then finally, based on physician billing records, it was reported that only 2% of older adults in Ontario received any services from a geriatric medicine specialist. So around the same time as this asset mapping project was happening, I began working with the Regional Geriatric Programs of Ontario to explore characteristics that would warrant referral to specialized geriatric services or referral for comprehensive geriatric assessment. And And so I'll come back to that briefly later, but part of where that work led me to was to take a closer look at home care clients in particular, and their contact with physicians, so more specifically geriatricians. Home care clients represent the most frail, functionally impaired, high needs, older adults in the community. And they're frequently in contact with physicians on an outpatient basis, with over 90% having any contact in 90 days with physicians in general, and almost 50% having 4 or more contacts during the same time period, so frequent contact during that time period. About 80% were in contact with family medicine, and over 1/5 had 4 or more contacts just with family medicine physicians. Other disciplines that they commonly saw included internal medicine, ophthalmology, cardiology, and the list goes on. What we found, though, was that only 5.2% of these older home care clients had any contact with a geriatrician. So that number is, more than double that of what we saw or what was reported in the general population. But we would expect that, it's still a small number, but we would expect that as these home care clients represent a subset of the older adult population who have particularly high needs. So I've seen this image or meme kind of all over the place these days. And I think it's kind of funny. Some of the vocabulary that's emerged during the pandemic. So anyways, I know some of you have heard me present on this topic before, and I don't have too much to say that's new, but I think it's a good time to revisit this work. While many of us may long for those so-called precedented times, the pandemic has shaken up our healthcare system, and we can't go back to exactly how things were before, even if we wanted to. So as you're, very likely already aware, there has been a decrease in physician services use across the board. This has been observed less so among family medicine, but to a greater extent among medical specialists and surgical specialists. The decrease itself was lower among subgroups of older adults and among the highest service users. That being said, there was still a decrease across the board in all of these groups. At the same time, there was also a decrease in home care assessments. So in particular, I'm talking of the standardized comprehensive clinical assessments, the intra-IHC assessments. So different forms of assessments were still happening, such as fillable PDFs and outputs or Word files. But because they stopped using the intra-IHC, in some jurisdictions, we lost valuable information and outputs that could be used for individual care planning, but also at an aggregate level for system planning. Older adults haven't just been affected by COVID itself, but by the blunt application of public health measures to contain COVID that they themselves may have caused adverse health, mental, and social outcomes. So with this decrease in contact with physicians and other care providers, including home care, older adults in the community have not been monitored to the same extent as they would have been before. Now, this is not to discredit any providers or others within the healthcare system who have been working tirelessly throughout the pandemic to support our older adults. You're all superstars, as far as I'm concerned, so I want to acknowledge your contributions and sacrifice in the midst of what's been very difficult circumstances. But as a result of these circumstances, there will be a segment of the population of community-dwelling older adults who have needs that worsened or emerged during the pandemic that may have been under-identified or underserved for a variety of reasons. So then, how do we address that within a system that already had limited resources pre-pandemic? In some ways, we now have an opportunity and a greater openness to do things differently. And that's why I'm coming back to this work that some of you may have heard me speak about before. A standardized decision support tool embedded in the regular home care assessment and care planning process could be used to rationally and equitably allocate limited specialized geriatric resources and SGS more broadly. As I mentioned earlier, home care clients represent the most frail, high needs, community dwelling older adults. As the home care sector resumes conducting standardized assessments more consistently again, they'll be well positioned to identify individuals who would benefit from SGS. And embedded decision support tools within these assessments could be used to capture reasonably sized target populations for referral to SGS and help to ensure more equitable and timely access to care. So the first place that we started was to look at the geriatric 5Ms. And so that's that communication framework used to describe the core competencies in geriatrics and communicates the services that are offered. It's meant to be used to guide referral to specialists in geriatrics as one of its uses. So the very first thing we did 3-ish years ago was to do a study of expert perspectives of need for referral to SGS or CGA. And in fact, some people, I know some people on the call actually participated as experts in this study. And what we found was what people reported as from their perspective was that the domains within the 5M, so being mind, mobility, medications, multi-complexity, and matters most, that those domains were consistent with the characteristics that were identified as important. Our next step was to look at who actually had contact with geriatric medicine historically. Now, the reason that we focused on geriatric medicine was because, as I mentioned before, it's very difficult to get a complete picture of SGS services use more generally. But we can use physician billing records to understand contact with geriatricians as a starting point. For that sort of first look, we looked at simple associations between certain characteristics in geriatric medicine, but we also looked at internal medicine and cardiology as a comparison. So that high service user, we define as having 3 or more physician visits in 90 days, as well as a hospital admission or ED visit. And those characterized as high service users actually had lower odds of contact with a geriatrician, but higher odds of contact with internal medicine or cardiology. The same goes for those with medical complexity or instability. So that was defined by, if you're familiar with the outputs of the intra-assessment systems, the CHEST score, risk of unplanned ED visits, again, that's the DIVERT scale, and COPD or heart failure diagnosis. So for each of those characteristics, they were associated with lower odds of geriatric medicine contact, but higher odds of internal medicine contact and cardiology contact. Conversely, risk of caregiver distress and institutionalization. So that's an output that's indicated by an output called MAPLE. That was associated with higher odds of geriatric medicine contact, but lower odds of internal medicine contact and cardiology contact. Now, the authors of the 5M framework did not provide like a specific operational definition for the domains, but we were able to map items from their conceptual definition that I had posted earlier to items that are in the home care assessment to develop a score. And the score ranges from 0 to 5 and indicates how many domains a person has care needs that fall within. And so with this particular score, clients with care needs in a higher number of 5M domains did have higher odds of contact with a geriatrician, but also a cardiologist, but lower odds of contact with internal medicine. Now, to summarize what's going on here, the findings revealed that the characteristics that are driving geriatrician contact tended to be the inverse of characteristics that drive internal medicine and cardiology contact. So the reason for why we might see this could be a reflection of the fact that there are barriers that exist, for example, wait times that prevent physicians from referring clients with more acute issues to geriatrics. But it may also be because there might be a lack of awareness or understanding that geriatric medicine does in fact have roots in internal medicine and has expertise in managing medical complexity and instability and conditions like COPD and heart failure among older adults, and not just dementia or other typical sort of old age stuff. We did take a closer look specifically at contact with geriatric medicine. And so I created a multivariable model predicting that contact in the 90 days post home care assessment. And the final model included the items listed. So we see here that conditions typical of old age, risk of caregiver distress and institutionalization were again seen to be associated with higher odds of contact, while there were other conditions and difficulty moving around that were associated with lower odds of contact. So the results that we see here are not entirely aligned with the factors that were identified in that first study of the expert perspectives, namely those 5M domains. It looks like there might be a segment of home care clients that are missing out on specialized geriatric care, despite having needs that are important, were identified as important for referral. There may also be some issues of accessibility for those who have mobility impairments that may act as barriers preventing access to care. Now, there's a lot we can't answer with a study like this. We don't know exactly what kind of factors are going on within the referral process, but this is sort of just a way to see what might be going on. George, do you want to jump in with any comments?
So I think, yeah, that's one of the key things that we've been finding is that as a profession, geriatric medicine has an idea of who it should be seeing. When you look at a population that is consisting of older people who are quite frail, I mean, they're in home care, the next stop is probably the long-term care facility. The patterns of referral do not match what, as experts, we think they should be. And again, there's multiple reasons for that we can think about, but clearly there's a deficit in our ability to provide the right care for these patients. And Sophie will have some very interesting outcome data to share with you.
Well, we also wanted to look at the relationship, thanks, George. We wanted to look at the relationship between family medicine and geriatrician contact to try to begin to understand what could be happening, in terms of that pathway. And here we found that frequent contact with family medicine did not appear to result in contact with geriatric medicine. But as contact with family medicine increased, there was a higher rate of contact with internal medicine, which again suggests that the clients have medical needs such as multimorbidity and may benefit from geriatric care, but there's something sort of getting in the way there. And so, whether that suggests the need for improved collaboration between community-based providers, or perhaps a greater awareness of the role of geriatric medicine, things aren't happening exactly as we would have expected. And there might be other issues, again, within the referral process and other barriers of care that might be coming into play that we just can't see from this sort of limited view. However, for some good news, we discovered that those who were in contact with geriatric medicine had lower odds of subsequent acute care services use, which is considered a win for many stakeholders within the healthcare system. However, the statistical significance and the effect size differed in various subgroups. So there was less benefit for those who are acutely ill, complex and unstable, and more benefit for the cognitively impaired and functionally impaired. So this might suggest a need for a more upstream approach where geriatric medicine or SGS is involved before a client has a high level of medical complexity and instability or a high risk of unplanned ED visits. So the same effects that we see from contact with geriatric medicine, we don't actually see with internal medicine or cardiology. I believe the next slide is hidden. Okay. The same goes for people with COPD and heart failure. If you zoom in on and stratify by those, the benefit, so meaning lower odds of acute care services use following contact with a geriatrician, is greater among those with COPD or heart failure. Again, it might be an opportunity to move more upstream in terms of involving those specialized geriatric services and geriatricians. I'm going to turn it back to George again to comment on that.
Basically, again, it's interesting because the geriatricians are internal medicine trained, those who go through the Royal College process, and not to discount those who have the care of the elderly certification. But again, the data were derived using OHIP billing numbers for geriatricians. So what's interesting to me here is that despite the internal medicine training and what appears to be a clear benefit, and if one looks at the literature on geriatric medicine in terms of the impact on ED visits and hospitalizations, these are pretty consistent. And so what we're finding is that of the 5% of these very frail people who get to see SGS backed up by a geriatrician, there is a significant impact on the odds of health service utilization that you don't really see with internal medicine or cardiology, whether the internists and cardiologists see them too late, or perhaps these specialties are not necessarily attuned to the management of the social complexities, the caregiver burden, and the cognitive issues. Regardless, I think it is good news for geriatric medicine, but given that this is a benefit that is only afforded to 5% of the long stay home care population, it begs the question as to how we address this from a systems perspective as the Ontario Health teams start coming together.
Thanks, George. So the next question that we had was, well, who should actually see a geriatrician, and how do we determine that? If from what we've seen, the people who were in contact with a geriatrician didn't represent sort of the full picture of who could benefit. So we're going to go back to those geriatric 5Ms. And as I said, we operationalized the 5Ms by using items from the comprehensive home care assessment to create that score that indicates the number of domains in which the client had care needs. And you can see the distribution of those scores here. It's definitely skewed towards the higher end, but that's to be expected given that this population of long stay older home care clients are known to have high needs. So this 5M score was found to be associated with higher odds of geriatric medicine historically, which we looked at already. And we found that the odds actually increased as the score increased. So someone with care needs in 5 of the 5M domains had 5.7 times the odds of contact with a geriatrician than someone who had no care needs within those domains, which represented, as you can see, a very small segment of the home care population. On the other end, 49, so that those top 2 levels, the 4 scores of 4 and 5, 49% of home care clients fell into those levels. And what we know of the limited availability of geriatricians and the high demand and need for SGS, this 49% would not be a realistic group for us to target for referral at this point in time. What we did then was to look at a combination of existing scales and outputs that could be used to capture a reasonably sized target population for referral. So not just to geriatricians, but to SGS more generally. And so we started with the 5M score to capture people who have needs that fall within the expertise of SGS. And then we added on MAPLE, which, as I mentioned before, is an indicator of caregiver distress and risk for institutionalization. And the components of this score include functional and cognitive impairment. And so with this, we would capture people who are already benefiting from contact with geriatric medicine. And then finally, we added in the CHESS score, which is an indicator of medical complexity and instability. And so with this, we would capture people who have those medical needs, who would benefit from care, but have not been in contact with geriatric medicine in the past. And so we put those together to create what we've called a geriatric referral algorithm. It has 3 levels, and the priority group 3 is the highest priority for referral. And when we did this analysis and ran those numbers against the sample that we have, keeping in mind that this was home care clients in the system between, just because of the data we had available, between 2012 and 2015. So those percentages might be a little bit different now if we looked at that today. But at the time, that was 9% of this home care population that we looked at. And then there was sort of a level 2, and then priority group 1, which would be the remaining home care clients, which are at the lowest level of priority for referral. Not that they wouldn't benefit or wouldn't be appropriate for referral, just if we had to prioritize, they would sort of be lowest priority. And with a system like this, we could avoid overwhelming current services, but also provide a strategy for building a larger service. Now I will turn it back to George to speak a little bit about a project that he was involved in, where they sort of took this idea and applied it.
Thank you, Sophie. And so I guess we will call it BC and AC, before COVID and after COVID. So this project was 1 year BC and then got interrupted. And we'll see how we can move this forward. But we were interested at the LIN level to see whether there was any correspondence between the home care clients identified as needing a geriatric assessment compared to what was already on the wait list for geriatric services in Waterloo, Wellington. And so the whole idea was to see whether, first of all, we could use the algorithm to prioritize people already on the wait list, but also to see whether there was, whether the people who were being seen were actually those who were at highest risk from a geriatric perspective in the home care setting. So we worked with the Waterloo Wellington LIN decision support to apply the 5M algorithm that Sophie just described in terms of the 3 tiers to the long stay home care clients in Waterloo, Wellington at that time. So this was in the first part of 2019. And so at that time, there were around 2,300 long-stay home care clients in Waterloo, Wellington. And when we applied the highest tier of risk to using the 5M algorithm, there were 143. And of these 143, between 2 and 3% had actually been referred to SGS. And so even basically among the highest risk individuals in home care, on the home care roster at that time, a very tiny minority were actually on the wait list to see geriatricians through SGS. And so the whole idea at this point, and again, it was derailed by the pandemic, but really the whole idea is to try to understand how we could link this all together so that folks who would be referred either through hospitals or through their family doctors who were referred to home care and who were deemed to be long-stay home care clients, how we could create a system whereby these people would be referred to a specialized geriatric service. And more importantly, what it did provide was an opportunity to look at the gaps in terms of geriatricians' numbers and provide a fairly evidence-based number of full-time equivalent geriatricians that could be hired in the region. And we all know that there's a very significant deficit. And the other point would be to make these referrals more automatic. And there is precedent for that. Right now, we basically refer based on the opinion of the referring physician. And while in many cases that works well, we have precedent in other systems where this doesn't work well. And that's why we now have stroke pathways, because leaving it up to clinicians to decide how complex older folks with strokes or any stroke patient would be managed was not as good as essentially establishing a stroke pathway. Likewise, acute MIs in a center with an angio suite, a cath lab, anyone who meets criteria for possible acute non-stable or an acute STEMI will go on to a STEMI pathway. And because we know that the quicker they get seen, the better their outcomes. And really what we're talking about in that sense is, how do you do this with home care? We know that they are all frail. These are very large numbers of frail persons. We can use validated instruments to determine their level of risk. And what we see is right now, those who are at high risk are not being referred. So as we think about how to apply this to understand how many full-time equivalent geriatric teams with geriatricians we can have, we also have a method to automate referrals to this team in order to essentially provide access to the best care for these folks. And the implications will be fewer hospitalizations, fewer ED visits. And the algorithm, the way that it was designed, was precisely to avoid flooding existing services. As we've seen, only 5% of long-stay home care clients right now are being seen by a geriatrician, either a geriatrician working alone, but more often with a team. And even the highest risk tier, that brings that number up to 9%. But starting there might be easier than essentially opening the floodgates to essentially increasing the number of referrals tenfold, just so that we can hit that 50% of people with 4 or 5 of the 5 M's. And so essentially we have an instrument now that can be used not only to support individual care planning, but to be incorporated into Ontario Health Team planning to understand how to develop, how to build capacity within geriatric services in order to really meet the needs of a fairly large segment of very high-risk individuals.
As George has already said, the cutoffs can be, adjusted based on capacity. And one thing that as I listened to Kelly Kay's presentation from last month, she raises some important questions to consider, such as what level of service do we want to plan for? What combination of health professionals are included in our model of integrated older persons care? And will we build capacity elsewhere to upskill in other areas and in that way support SGS capacity? And I think those are great questions to think about as we sort of, consider what's our target and adjust the cutoffs based on that. And we also recognize like this home care, this idea of, starting with home care, while it represents the most frail of the community dwelling older adults, it's just one piece of the puzzle. And as well, this is a solution that will only work if multiple sectors of the healthcare system come together. It's not something that home care alone can sort of champion and or that geriatrics alone can sort of take up. It's something that different sectors need to come together to support older adults in the community. And so I think OHTs represent a real opportunity to make a solution like this, whether it's this or something else, to make something like this really work to improve care for older adults in the community.
Mm-hmm. I'll add that there is precedent in the literature in the United States where they developed a similar process. They used insurance billing information to identify higher risk individuals, higher risk in terms of hospitalization and ED visits, and created within the context of their home care services a service that was led by advanced practice nurses and occupational therapy. And these people would are seen based on these criteria. The physicians, the family physicians, the primary care physicians are on board with these referrals. So the determining factor is based on essentially these criteria. The individual is assessed by that team in the community. That team has expertise in multimorbidity and geriatric issues. They will work for the lower risk individuals. They will work with the family physician to establish a plan of management, and they will also bring in geriatric services for those who are at higher risk. So the precedent exists. They have shown in a clinical trial that this approach does reduce acute care utilization. It takes a few years to demonstrate, and what was interesting in their clinical trial, which they conducted for a couple of years, is they found that in the first year, the teams had to figure out how to work with one another because this was obviously something that they weren't used to doing. But once the team and care processes became synchronized and efficient, there was a significant reduction in acute care utilization and improvement in the health and the quality of life for the individuals involved. So there is precedent, and we have a similar mechanism here that can support this kind of redeployment and integration of our services.
All right, so before we finish, I just want to acknowledge my PhD supervisor and committee, as well as the RGPO, Kelly Milne, my colleagues Melissa Zeraldo and Ian Zarin for their support for this project, ICS for the data for this project, as well as the Ontario Ministry of Health and Long-Term Care and the Geriatric Priority Service Working Group. And so be happy to move on to some questions now. Thanks so much.
Great. Thank you, Dr. Hogeveen and Dr. Heckman, for a very fascinating presentation. So while we're waiting for people to ask some questions, I have a couple. What's interesting is I did a quick calculation, and for the geriatric outreach team here in Ottawa, we're getting the same data. So 2.5% of our referrals are from home care only, yet we refer 30% to home care either as a new referral or increase existing. So it sounds like we're on track. I just wondered if you had a chance as part of the study to talk to home and community care specifically around what are the barriers and facilitators for their lack of referral or when they do refer to SGS.
Thanks for the question, Heather. Yeah, so we did not have a chance as part of this study to speak to the home and community care sector about that sort of part of the process, but it's definitely something that we're interested in. You know, as the case for everyone, the pandemic kind of put our follow-up plans on hold, but there is interest in asking those questions. One thing that we have heard, though, or I've heard and working with different organizations is, as I was it, I don't think it was referenced earlier today, but maybe in the last month's rounds, the fact that for in some regions, the referrals can only come from primary care, for example. So it makes the process a bit more complicated. And it's something that we'd have to, work through that process of care, whether things are changed so that a referral can come directly from home and community care, or if the process is that home and community care flags to primary care, that a referral might be recommended. So yes, that's definitely a piece of the puzzle that is important to take a closer look at.
Mm-hmm. In fact, the Lynn was quite interested, and they were the ones who spearheaded that initial comparison of existing wait lists with the current population of long-stay home care clients. And there's a lot of inertia when you're trying to get these things to align. A lot of inertia in the sense that this is not how we do things, and this is not how we do business. And you've got to get people to sort of take a step back and think about the patient. And so often some of the barriers are related to, we've got our nose to the grindstone and we can't possibly reimagine how we would work and collaborate. But I think you have to go and look back at at the population. And if we're dealing with long-stay home care clients, they have extremely high event rates. Most of them have ADL issues. Most of them have cognitive issues, multimorbidity. To paraphrase, this is our lane in terms of SGS. The primary care angle, again, we're thinking about, well, gosh, we can only see someone if we have a referral. These folks have been referred to home care, and if you make home care services, if you include an SGS referral as part of the potential options of home care services, the physicians who refer to home care can always opt out, but I suspect most won't. But I think there's ways around this, and we just have to sort of think outside of the box. We always want to be conservative with how we organize our work. And sometimes there's inertia from this is the way we do things. There's inertia from an administrative perspective. There's perceived inertia from the perspective of funding. But I think we need to go back to the patient characteristics and say, just like people did with acute MIs, way back before there were cath labs all over most of Ontario, people with acute MIs who would benefit from an angiogram and a stent were not referred, and they had poor outcomes. And we have the same thing here. 5% of a population that would benefit immensely from seeing SGS, only 5% is seeing the service that would result in very significant improvements to their health. So we really have to think about that as the bottom line.
Yeah, I agree. I mean, I just wondered anecdotally, I mean, we take direct referrals from home care, so that takes that piece out of the puzzle. But I just wondered anecdotally if my sense is anecdotally, I feel they are already doing a CGA based on their assessment and understanding or thinking that services answers that question rather than kind of that investigation root causal kind of analysis. It's just anecdotal, and I didn't know if that is something that you had has been validated. So
I think it needs to be done as a study, but I've seen it. I mean, I've seen my father's home care assessment, and some of the issues that could have easily been dealt with by physicians, like pain, were kind of marked off as deferred by the home care case manager. I don't know that happens a lot, because no one's done the study, but again, it's the way we practice. We practice in silos, and if something comes up that is not within our specific expertise, like heart failure management or pain management, or the cardiorespiratory trigger is raised, we don't have the current systems in place to say, you know what, I think I'll refer you to the geriatrician today. And as you said, there's a bunch of information that's collected, and it's simply, the task is to make that information understandable to the physicians so that they can get an idea of what that person looks like and go in and focus in on the more acute issues.
Great, thank you. We have another question. So Taryn, who is with one of our day hospitals, would like clarification on how you quantify the matters most in your 5M scoring, which is a great question.
Yeah, definitely. So I will say that one was the toughest one. So the definition for that was each individual's own meaningful health outcome goals and care preferences. So the way that we quantified that one is, for each of these, we went through the whole home care assessment to see what might make sense. So for that one, we flagged there's an item on self-rated potential for improvement. So if somebody identifies that, there's a self-reported health. So if somebody self-identifies poor health, and then there's also an item for better off living elsewhere. So if it's identified by the person or their family, that they feel that they would be better off elsewhere. So we flagged that one as also, those were the 3 items that went into that. But yeah, as I sort of alluded to before, it is always a bit tricky when you've got sort of definitions like this to then operationalize those. But if we started off with like the 4 or 5s, we already know that a good chunk of the home care population will fall into a 4. Even if they don't check off all 5, they'll hit the 4. So yeah.
Great. Any other questions? I had one about, I guess, this decision algorithm. Is it only built within the Inter-I? I'm on a design team for the frail older adult, for the Ottawa Health team. So I'm just wondering, or is it available for use now, or how do we access it?
Yeah, so that's so it was built off of the home care instrument, the Inter-I home care instrument. So to get all of the scores needed to calculate that, you would need most of those. Now there are we're working on sort of translations to be able to get the same score, not just from the home care instrument, that we could also get it from some of the other Inter-I instruments. But that being said, it would be difficult sort of outside of the Inter-I assessment world to get the exact same score without having that sort of comprehensive standardized information set. So I guess to answer your question, yes, right now it is more so limited to care settings where the NTR tools are used.
Basically, the flag would be triggered as soon as the instrument is completed by the home care client. So you could automatically flag the person for referral.
Thank you for a great presentation this morning, and hopefully you're able to continue pick up where you left off as things become available. I just want to thank you for your time and for your information today. And just to remind people that the next Geriatric Rounds is on Monday, March 22nd at 8 a.m., where we'll be talking about the Geriatric Education Series that the RGPO has been offering for 20 years, sort of talk about the evolution of it. And we just hosted it online a few weeks ago. So we'll talk about the evolution and the feedback of the series. So thanks everyone for joining us this morning on a Monday morning, and have a great day.